And now, with the final part of the presentation, lung ultrasound in abnormal conditions. Firstly, we'll start with one of the most common respiratory problems in ICU, pneumothorax. Spontaneous pneumothorax, traumatic pneumothorax, whatever, pneumothorax and mechanical ventilation. So it's frequently happening in ICU patients. Pneumothorax can be recognized by lung ultrasound by 4 signs: 2 absence, 2 presence. Absence of lung sliding. On the previous part, we saw and we knew what is lung sliding, what does it look like. So in pneumothorax, it is absent. Absence of lung pulse. Lung pulse is transmitted cardiac pulsations to the pleural line. We'll see in details now. On M mode, presence of stratosphere sign and absence of seashore sign. Number 4, presence of the lung point. In details. On the left side, this is the normal lung sliding. Again, this is the pleural line, dancing, moving backward, forward, all the time. And these lines, Z lines, moving with the pleural dancing or pleural sliding. This is normal. In pneumothorax, there is air collection between parietal and the visceral layers of the pleura, so there will be no sliding anymore, like this. This is the pleural line, see? It's not dancing. Fix it. Don't be confused with the movement of the whole chest wall, but look at the line itself. It's not sliding. Again, if we can compare that side with that side on the same time, look at the difference. Now it's easy. Positive lung sliding, no pneumothorax, no lung sliding, suggestive for pneumothorax. And I say suggestive because there are some lung diseases which can limit lung sliding, especially if you have severe restrictive lung disease like ARDS. So the lung movement, by its nature, by the disease nature, is very limited, and there will be almost no lung sliding. So don't ever depend on absence of lung sliding alone to judge whether there is pneumothorax or not. We have to draw the whole picture through searching for the other signs. Now let's move to the second sign, the M mode. Do you remember the previous part when we did the M mode through the normal lung? It was like C, sure sign. So that was the pleural line and the muscle layer forming the ocean, the lung forming the sand. If there is pneumothorax, there will be air collection between the parietal and the visceral layers of the pleura, pushing the lung away, so the whole field would be like this. It's called barcode sign or stratosphere sign. This is confirmatory sign for pneumothorax. So simply, if you are confused about whether there is lung sliding or not, bring the cursor, do M mode, and if you find stratosphere or barcode sign, that's it. This is pneumothorax. So we can diagnose it within 10 seconds, 20 seconds. Very quick, very easy. Third sign is the lung point. We need to move with the probe from the medial to the lateral along this line, like this or like this, to check for the lung point, which is the point at which the two layers of pleura rejoin together again. So at that point, you can find seizure sign on the normal side and the stratosphere sign on the other side. So let's describe it as the transition zone between the normal part and the pneumothorax part. And of course, if the pneumothorax is complete all around, you will not find the lung point. So it's not necessary to find the lung point to diagnose pneumothorax. It's not necessary. Finally, absence of lung pulse. Lung pulse is the transmitted cardiac pulsations to the pleural lines. Can be seen here in the B mode. Look at the pleural line, it's pulsating. These are transmitted pulsations from the heart to the pleural line. Again, it's pulsating. We can appreciate lung pulsations on M mode. So this is ECG trace. With each QRS complex, we will appreciate this longitudinal line of vibration, cardiac pulsations transmitted to the pleural line. So it's logic, in presence of pneumothorax, the transmission of cardiac pulsation would be very difficult and the lung pulse would be absent. Those are the 4 signs of pneumothorax by lung ultrasound: absence of lung sliding, absence of lung pulse, presence of lung point, presence of stratosphere or barcode sign. Second problem, pleural effusion. The ultrasound is generally very sensitive in detecting pleural effusion. In chest X-ray, you need at least 500 ml of fluid to be detected by chest X-ray, but ultrasound can detect a minimal amount of pleural effusion. So, how does it look like? Again, this is the marker, so this is the lung, diaphragm, liver, and as we mentioned in part 1, this echoic fluid is pleural effusion. And this is the collapsed lung. So it's anechoic space of pleural effusion compressing the lung like this. So when the lung moves inside huge amount of effusion, they call it jellyfish sign. This is the jellyfish. So this is jellyfish sign. And we can estimate also the volume of pleural effusion as well by ultrasound. So to summarize the signs of pleural effusion by lung ultrasound: anechoic region, plaque region above the diaphragm. This is the diaphragm, liver, lung, and this is the marker towards the patient's head. So anechoic area is the first sign. Lung collapsed, this is the second sign. Third sign is absence of curtain sign. Do you remember the curtain sign? Presence of water or pleural effusion compressing the lung, so the lung can't move to take over the liver like curtain sign. So absence of curtain sign. And number 4, positive spine sign. Because of presence of the pleural effusion, as you know, fluid can transmit ultrasound wave better than air. That's why I can now see the spine below the diaphragm and above the diaphragm. Under normal conditions, if there is no effusion and all of this area is air is very bad conductor to ultrasound wave, and you shouldn't see the spine like this. So anechoic areas, lung collapse, absent curtain sign, and finally positive spine sign. This is for pleural effusion. Now, interstitial syndromes. Any water overload in the interstitial compartment is responsible for what's called interstitial syndrome. So the differential diagnosis here is cardiogenic pulmonary edema, the classic one, and the non-cardiogenic pulmonary edema, which is ARDS, and interstitial pneumonia or pneumonitis. All of them can cause this interstitial syndrome, water overload on the interstitial compartment or water leakage on the interstitial compartment, whatever. So what I can get by ultrasound here is those hyperechoic lines extending from pleural line down to the whole depth of the screen. They are called B lines. You can acknowledge one or two B lines normally on the single intercostal space, but more than three is always pathological. So we need to appreciate three or more of those B lines to confirm that this interstitial compartment is water overloaded or inflamed. So the differential diagnosis here is cardiogenic pulmonary edema. On this one, the B lines would be corresponding to careless B line in chest X-ray. And the non-cardiogenic pulmonary edema, ARDS, or interstitial pneumonia or pneumonitis. So again, hyperechoic lines should be three or more, extending from the pleural line down the whole depth of the screen. Previously, they were called comet tails. This is the comet tail. ديل المذنب. comet tails. خيالهم حلو قوي في التسميات الصراحة. Ultrasound feature, comet tails or B lines. The differential diagnosis, cardiogenic pulmonary edema, ERDS, interstitial pneumonitis. So simply, if you get the patient with cardiogenic pulmonary edema, hypertensive cardiogenic pulmonary edema, just put the ultrasound probe, look for B lines. That's it. Don't request for chest X-ray and waste your time. Very quick, 10 seconds. Search for multiple B waves. That's it. Also, we can consider presence of multiple B waves as a sign for volume overload, and it can guide our fluid management as well. So consider every patient with multiple B lines like this as volume overload, and give him fluids very cautiously. This is the second benefit from B lines as well. Comet tail, nice. Alveolar syndrome, or simply consolidation. So in pathology, the third year faculty of medicine, the alveoli should be vacant spaces filled with air. If there is pneumonia, they will be inflamed and filled with cells and inflammatory cells. So it's going to be hepatized. That's what's happening on ultrasound exactly. So now, if this is the diaphragm, liver on the right side of the screen, lung on the left side of the screen, I can see the lung tissue now like the liver exactly. This is tissue-like sign or hepatization. This is the first sign. Also, we can acknowledge these white lines, which is air bronchograms. This is air bronchograms, which is good sign for pneumonia. Look at the video. Consolidation. So to summarize the signs of consolidation on lung ultrasound: tissue-like sign or hepatization, the air bronchogram, those hyperechoic spots or lines, air bronchogram. This is air bronchogram. And the last sign, something called the shred sign. Shred sign, this is the, if you look at the interior border of the pneumonic part, when it is close to the normal site where there is no consolidation, you will find it like shredded and interrupted, very irregular border. This is the shred sign, very sensitive sign for pneumonia. But most importantly and easier to be detected is hepatization and air bronchogram. So finally, if I am on call on ICU and I get the patient with acute severe dyspnea and acute respiratory failure, how can I get benefit from the lung ultrasound? There is what's called the blue protocol. It stands for B for bedside, L for lung, U ultrasound, E emergency. So it's bedside lung ultrasound in emergency, blue protocol. In acute respiratory failure, studies found that lung ultrasound can provide a diagnostic accuracy of 90% compared to 75% for physical examination and chest X-ray combined. So especially it's a very quick scan which takes less than 5 minutes. So it's worth to try doing lung ultrasound quickly, and mostly you will catch a diagnosis by lung ultrasound. How should we do it? First step, search for lung sliding anteriorly and look for B lines at 2 anterior points on each hemithorax. Let's say on the right side, superior anterior, inferior anterior, and the same on the left side. Absence of lung sliding should be suggestive for pneumothorax. Presence of lung sliding, rule out pneumothorax. B lines to cover the possibility of cardiogenic pulmonary edema or ARDS or interstitial pneumonitis, interstitial pneumonia. So, if I found nothing by that step, what's next? Scan the legs veins for DVT, also by ultrasound. This is another topic, another lecture. If you find DVT, so I would suggest pulmonary embolism as a reason for his acute respiratory problem. If I found nothing, move to step number 3. Look for consolidation on the posterolateral part. So put your probe on mid-axillary line, right side and left side, and check for consolidation carefully. So this is the way we covered everything. Pneumothorax, interstitial syndromes, cardiogenic pulmonary edema, ARDS, interstitial pneumonia, pneumonitis, pulmonary embolism, pneumonia. And this is the differential diagnosis already of acute respiratory failure. We can get all of them by quick ultrasound examination, less than 5 minutes. This is the blue protocol. I would advise, try to do that in next 10 patients of acute respiratory problems you will see in ICU unit. Try doing blue protocol, and at the end of this presentation, I would say practice, then practice, then practice. Practice the normal lung ultrasound. Master the views, the anterior views, lateral views, posterior views of lung ultrasound. Keep practicing all the time. Leave the abnormal signs away for now. You will get it by time. And then, after mastering the normal lung ultrasound, try to check for abnormal signs. If you have a patient with very clear chest X-ray for pneumonia, try to catch the consolidation by the ultrasound. Train yourself to do so. If you have ARDS patients, just put the probe and look for the B lines. If you have a patient with pneumothorax, train your eyes on the stratosphere sign and absence of lung sliding, absence of lung pulse, and those signs. So keep practicing like this, and you will find the lung ultrasound very accurate and a quick method to detect respiratory problems in ICU. Finally, if there are any questions, we have my senior, Professor Dr. Saeed Qinawi, and he offered that he might spend 1 hour, like 1 hour or 2 hours with us by Zoom program if there are any advanced questions about that topic. If anyone interested, please send your name and your email in a comment. Thank you.